Hello everybody. Today's topic is ARDS. So ARDS is the clinical syndrome, not a disease, and it is characterized by the diffuse alveolar damage, inflammation, and edema causing acute respiratory failure with impaired gas exchange and oxygenation. Global awareness of ARDS is increasing and it is recognized as heterogeneous syndrome with direct or indirect causes presenting with the wide range of clinical and pathological characteristics. So this is the new global definition of ARDS. So in this, it is mentioned that intubation is not always required for the diagnosis. Even if the patient is on the high flow nasal oxygenation of more than 30 liter per minute, and if the NIV with the CPAP level of more than or equal to 5 centimeter of water of PEEP is there, then that is the number one criteria. Then the hypoxemia level of the PaO to FiO2 ratio of less than or equal to 300, SpO2 FiO2 ratio of less than or equal to 315 with SpO2 of less than 97. Then third criteria will be the bilateral opacities confirmed by one of the following, that is chest radiography, computed tomography, or ultrasound with well-trained operator. So clinical disorder that lead to the development of the ARDS. So it is caused by direct injury like pneumonia, pulmonary contusion, inhalational injury, reperfusion injury, and fat emboli, and indirect injuries like sepsis, multisystem trauma, and less common causes are transfusion of plasma, acute pancreatitis, drug overdose, and cardiopulmonary bypass. Now, regarding pathogenesis, ARDS is a condition initiated and triggered by the injury to alveolar epithelium or endothelium. Alveolar epithelial injury is the initial insult in the condition associated with direct lung injury. Capillary endothelial injury is the initial trigger in condition associated with the indirect injury. So alveolar epithelial, there are of two types, that is flat one or cuboidal type 2. Type 1 are more prone to injury and type 2 are responsible for the production of the type 1 transfer of iron and less prone to damage. Loss of the type 2 lead to the loss of usual transport and the removal of the fluid. Now there are three phases of ARDS, that is exudative phase. It occurs due to injury to the alveolar epithelium and endothelium. Then the second one is the proliferative phase. It starts 7 to 14 days after initial insult and lead to repair of the damaged epithelium and endothelium and restoration of the barrier function and the proliferation of the fibroblasts. Then fibrotic phase occurs in some patients as a chronic inflammation sets in, leading to the fibrosis. The most common feature of ARDS is the widespread loss of the alveolar epithelium type 1 due to sloughing and apoptosis. One of the well-known marker of epithelial injury is the receptor of advanced glycation end product that is highly expressed on the alveolar epithelial cell type. So alveolar fluid in the ARDS is rich in the protein. The injury to the endothelium causes release of inflammatory molecule, increased expression of cell surface adhesion molecule, that is selectin, and the intracellular adhesion molecule, activation of the procoagulant pathway by increased release of von Willebrand factor, especially in the patient with sepsis and bacteria. Other abnormality contributing to the pathogenesis of ARDS are as follows: neutrophilic infiltration leading to inflammatory cascade, surfactant dysfunction, dysregulated intravascular and extravascular cascade. Neutrophil plays the critical role in the initial inflammation cascade. Neutrophil release variety of the protease, that is elastase, collagenase, gelatinase A, and gelatinase B, in addition to the pro-inflammatory cytokines and chemokines. All these lead to widespread inflammatory process, lead to both inflammatory and extrapulmonary damage. The surface dysfunction is combined result of injury to type 2 epithelial cell and the intraalveolar flooding with the proteinaceous fluid and increased proteolysis. Then the dysregulated intravascular and extravascular coagulation is mainly due to activated leukocytes and endothelial cell, both increase procoagulant activity and impaired fibrinolysis. Tissue factor expression is increased on the surface of alveolar epithelium, and resistant macrophages lead to the increased procoagulant activity. Elevated level of plasminogen activator inhibitor 1 and the reduced level of protein C results in the impaired fibrinolysis. Now, the pathophysiological consequences of ARDS is refractory hypoxemia and shunt, decreased lung compliance, and pulmonary hypertension. So first we'll see refractory hypoxemia and shunt. Flooding of the alveolar space with the protein exudate in the fluid. Alveolar collapse due to increased surface tension in the absence of surface tension. Then non-cardiogenic pulmonary edema. And this will lead to the VQ mismatch. Inflammatory edema results in widened alveolar septum, results in impaired diffusion. Then there will be the decreased compliance. Alveolar flooding and the atelectasis, along with capillary membrane inflammation, makes the alveolar space still and results in the non-compliance. Then pulmonary hypertension and RV failure. Pulmonary hypertension develops due to hypoxic vasoconstriction and also due to local production of endothelin 1 and thromboxane 8. Now, this pulmonary hypertension lead to hypoxemia by right to left shunting. And pulmonary hypertension will worsen hypoxemia by increasing dead space ventilation and hypercapnia. So, this is the treatment line for ventilation for the management in the ARDS. Now, we'll see the one by one what it is. So first is tidal volume. The cornerstone for the lung protective ventilation is the ARMA trial, which demonstrates that the low tidal volume, which is equal to 6 ml per kg of predicted body weight, compared to the higher tidal volume of 10 to 12 ml per kg of predicted body weight, improved the survival. Recent trials and the meta-analysis recommended use of the tidal volume. However, low tidal volume ventilation is often underutilized for the ARDS. A multi-centered international prospective observational study across the 50 countries, including 3,000 to 3,022 patients with the ARDS, reported, which is a lung safe trial, reported that ARDS was recognized only 60% of time by clinicians, and less than two-thirds of the patients with ARDS received tidal volume of less than 8 ml per kg of predicted body weight. A study with the 482 patients with ARDS found that every 1 ml per kg increase in tidal body weight, a tidal volume above 6.5 ml per kg, was associated with 23% increase in mortality in the ICU. The ARDS NET trial, which reported that ventilation with high tidal volume within the initial 48 hours was not associated with uh, increased hospital mortality. So the lung protective ventilation targeting low tidal volume and plateau pressure should start in the emergency department. The LOV-ED investigator found that implementation of ARDS protocol in the ED with low tidal volume and P-plat resulted in the high probability of using low tidal volume in ICU, leading to the less risk of ventilator-induced lung injury and lower mortality. So the current guidelines and the clinical approach suggested that individualizing mechanical ventilation according to the patient and disease characteristics, targeting tidal volume of 4 to 6 ml per kg without exceeding tidal volume of 8 ml per kg of predicted body weight. Then we need to target the P-plat levels of 30 centimeter of water, because higher values contribute to over distension of alveoli, leading to lung damage and mortality. Then the next concept is the ventilator asynchrony. Asynchrony event can be quantified by the asynchrony index, which is defined by asynchrony event divided by sum of the ventilator cycle. So evidence suggests that if asynchrony index is more than 10%, then it may be associated with ICU in the hospital mortality. Common asynchrony include triggering asynchrony, cycling asynchrony, flow asynchrony. Now, the ineffective triggering when the patient respiratory effort do not result into the ventilator delivered breath and is improved by increased triggering sensitivity of the ventilator or by flow trigger. When ineffective triggering is due to excessive intrinsic peak, then efforts are directed to reduce intrinsic PEEP or increase external PEEP to 75% of intrinsic PEEP to decrease the pressure gradient required by patient to trigger ventilation. Then cycling asynchrony occurs when cycling from inspiratory phase to the expiratory phase is premature or delayed. In premature cycling, the patient respiratory effort continues during expiratory phase, resulting in double triggering and breath stacking. This is addressed by increasing inspiratory time in pressure control or by decreasing tidal volume or by decreasing flow in the volume control. The opposite occurs during delayed triggering and is corrected by decreasing inspiratory time and increasing flow in volume curve. Now the next is flow asynchrony, occurs when the patient's flow demand does not match the ventilator. Flow starvation often occurs in volume control where patient exhibit excessive ventilatory demand and typically sub down the pressure time waveform. Increasing flow or changing the pressure control mode can improve asynchrony. Excessive flow can be improved by decreasing the flow in volume control and decreasing the inspiratory pressure. Now the next is PEEP. Regarding PEEP, there are four large randomized clinical trials, that is ART trial, alveolar trial, EXPRESS trial, and the LOV trial, which is comparing the high PEEP with the lower PEEP strategies, and all fail to improve survival with high PEEP, except ART trial. Interestingly, the only ART trial reported higher mortality in the presence of high PEEP level. There was not solely related to the high PEEP level, and extensive recruitment maneuver at that time was also applied. Therefore, the underlying pathophysiology, lung mechanics, and degree of recruitability need to be monitored to evaluate the effect of the PEEP. Moreover, the higher PEEP may result in detrimental hemodynamic effect, thus increasing shunt, dead space, and right ventricular afterload, as well as reducing cardiac output. The assumption that higher PEEP may lead to recruited lung unit is often not observed, and it may result in overinflation and reduced lung compliance. Carbon dioxide gap as a marker of inadequate peripheral O2. PET CO2 and PaCO2 to investigate in those patients with ARDS who may need physiological dead space monitoring as a global index of the efficiency of lung and PEEP sit. There is no clear mortality benefit in ARDS when comparing high PEEP with low PEEP strategy in all patients receiving low tidal volume ventilation. However, there may be benefit in patients with moderate to severe ARDS, particularly in patients who are PEEP responsive, defined as increasing PF of more than 25 mmHg after higher PEEP. Because of the significant heterogeneity in ARDS, different phenotypes may respond differently to the PEEP. Therefore, clinicians should monitor oxygenation and lung compliance during titration. So PEEP titration is performed by making stepwise increase in the PEEP, followed by small decremental changes of 2 cm every 2 to 5 minutes, while checking PEEP plat and monitoring changes in the lung compliance. If a patient's oxygenation and lung compliance worsen with the increased PEEP, the PEEP is too high, whereas if they improve, the titration can continue until no further improvement is observed. So more advanced method of individualizing PEEP include stress index, electrical impedance tomography, esophageal pressure guidance. The stress index is based on the pressure or time curve during constant flow, volume control ventilation. So in that, if there is a linear pressure rise, it suggests the recruitable alveoli without over distension. If that is stress index is equal to 1. If there is increasing compliance as the lung is inflated, that is concave down waveform, suggests the tidal recruitment, which is benefit and benefited from uh, increased PEEP. Conversely, the decreasing compliance as the lung is inflated, that is concave upward, that means the stress index is more than 1, suggests the over distension and it may benefit from decreased PEEP. So stress index is not superior to the other PEEP titration. Now the next is esophageal impedance tomography, determining the PEEP with least over distended and collapsed lung. The study of severe ERDS, the esophageal impedance tomography guided PEEP titration improved oxygenation, compliance, and driving pressure. Finally, esophageal manometry can be used to guide PEEP and operate under assumption that esophageal pressure is equivalent to the intrapleural pressure. So PP is titrated to the transpulmonary pressure of 0, where transpulmonary pressure is equal to the airway pressure minus esophageal pressure. Which and in this PAO is the airway pressure and the esophageal pressure will corresponds to the pleural pressure. So P plat and the PEEP can represent the airway pressure as alveolar distending pressure at end inspiration and end expiration respectively. In the IPVEN trial, the esophageal pressure guided PEEP titration improved oxygenation when compared to the high PEEP. When compared to the empirically high PEEP in the IPVEN 2 trial, there was no difference in the clinical outcome. The post-hoc analysis of the IPVEN 2 trial demonstrated that PEEP titrated to the end expiratory pleural pressure of 0 was associated with the greater survival than more positive and more negative value. So ideal goal of esophageal manometry to guide PEEP include end inspiratory pleural pressure should be less than 15, end expiratory pleural pressure should equal to the 0, and transpulmonary driving pressure should be less than 10 to 12. So this is the diagram which is indicative of stress index. And the first diagram, as we can see, when the there is a flow, this is the volume control ventilation, which is indicative of the pressure and the flow. When the stress index is less than 1, then we have to increase the peak. The linear straight line indicates the stress index is equal to 1. That means no need to change the peak. And if it is the concaving downward, then that means the stress index is more than 1. That means PEEP need to be reduced. Then the second diagram is showing is indicative of the electrical impedance tomography, which is performing decremental PEEP titration to find intercept of collapse and over distension curve. And the third is the esophageal manometry method, in which we are titrating PEEP based on the esophageal manometry. So if end inspiratory pressure, and the goals of this are end inspiratory trans pulmonary pressure should be less than 15 to 20. Then end expiratory transpulmonary pressure uh, should be 0, and the transpulmonary driving pressure should be less than 10 to 12. So the newer and the elegant method of determining lung recruitability by the PEEP is the recruitment to the inflation ratio, where the ratio of more than or more than 0.5 suggests lung recruitability at higher. So regardless of the method used for the PEEP titration and the metrics used assessing efficacy, monitoring hemodynamic response is also necessary. So PEEP can decrease the cardiac output, which can decrease the peripheral distribution of oxygen despite increasing oxygen saturation. Conversely, PEEP can reduce the LV afterload. Therefore, individualized PEEP titration should consider oxygenation and driving pressure as well as hemodynamics. Now, next concept is the driving pressure and the plateau pressure. Driving pressure and the descending pressure represents the ratio between tidal volume and respiratory compliance, which can be easily obtained by the PEEP at bedside. Driving pressure offers the accurate picture of the optimal lung mechanics in ARDS by estimating tidal volume and respiratory compliance, which correlates with the aeration of the lung. Therefore, driving pressure represents the easy estimator of strain, that is tidal volume upon aeration of the lung at end expiration in ARDS. The concept of the baby lung in the ARDS was defined as fraction of lung parenchyma that still preserved normal inflation. And its size depends upon the severity of ARDS and relates to the static lung compliance. The driving pressure depends upon the tidal volume as well as on the relative balance between the amount of aerated and the overinflated lung at end expiration and end inspiration at different level of the peak. So high driving pressure. So the high driving pressures are independently linked to the ARDS mortality. So the Amato et al. Reanalyzed the data from 3,562 patients from 9 trials and found that the driving pressure was the variable that best stratified the risk, and reduction in the driving pressure were strongly associated with the increased survival. The association between driving pressure and mortality was also observed in the lung safe trial. The newer analysis suggests that the mortality benefit seen in lowering the tidal volume varies with the respiratory system compliance and with a greater benefit seen in the higher lung elastics. Lowering tidal volume to reduce the driving pressure resulted in the greatest benefit in patients with the low lung compliance. So optimizing the ventilatory setting to achieve the driving pressure of less than 15 may be the preferred type. There are ongoing clinical trials to investigate the driving pressure driven approach to ventilator management. Now the next is airway pressure release ventilation. Airway pressure release ventilation is an alternative mode of mechanical ventilation used to treat refractory hypoxemia and ARDS. Airway pressure release ventilation is pressure limited mode that cycles between the two level of the continuous air pressure airway continuous positive airway pressure. The higher airway pressure set for the certain time, the lower airway pressure is set for the shorter time. APRV utilizes the inverted inspiration and expiration ratio as majority of the spontaneous breathing is accomplished during the T high with higher pressure theoretically allowing for the recruitment of collapsed alveoli and the T low allowing for the ventilation and complete exhalation. The proposed benefit of the APRV include allowing for the spontaneous breathing, decreased work of breathing, and less dysynchrony. It is also thought that the high mean airway pressure may improve the oxygenation when compared to the more conventional mode of the mechanical ventilation. While APRV may increase the mean airway pressure, there is less control over tidal volume and minute ventilation. And some patients may also require deep sedation or paralysis, thereby eliminating spontaneous breathing, compromising adequate ventilation. These issues may be overcome using time control adaptive ventilation, where TLU is set to terminate at 75% of expiratory fluid peak, maintaining adequate alveolar inflation during the release phase. If patient requires high minute ventilation, T high is reduced to increased frequency of release, while the T low remains set based on the expiratory flow dynamics. Despite its use in the ARDS, high-quality evidence favoring APRV is lacking and available study reported mixed results. A systematic review and meta-analysis of 8 studies found that use of APRV in critically ill patients with acute hypoxemic respiratory failure was associated with improved mortality and oxygenation, although these studies are small and single-centered studies. Another systematic review and meta-analysis of 6 studies with 375 patients found that APRV was associated with improved oxygenation, decreased ICU length of stay, but had no effect on the mortality. So more recently, randomized control trial of 90 adult patients with COVID-19 related ARDS compared APRV with the conventional low tidal volume ventilation found that APRV was not associated with improvement in ventilator-free days or mortality. So large multi-center randomized study are needed to further clarify if APRV is beneficial in patients with severe ARDS compared with the conventional ventilation. Now the next is high frequency oscillatory ventilation. Now, high frequency oscillatory ventilation is the mode of invasive mechanical ventilation that employ constant airway pressure with oscillations at extreme respiratory frequencies, delivering tidal volume well below that anatomical dead space. So gas exchange is by convection and diffusion. In larger airway, convection predominates where gas flow is dependent on the turbulent flow, bulk convection, and central airway oscillation pressure. In the lung periphery and alveolar unit, diffusion predominates where gas flow is dependent on the tailored respiration, collateral ventilation, pendulum, and cardiogenic mixing. In lung periphery and alveolar unit, diffusion predominates where gas flow is dependent on tailored respiration. So higher collateral ventilation, pendulum, and cardiogenic mixing. The higher oscillatory pressure recruit the atelectatic alveoli, but are dampen the aerated alveoli. In small airway and mid-lung zone, both convection and diffusion direct the gas flow and are dependent on turbulence, peripheral airway resistance, pendulum, asymmetric inspiratory and expiratory flow ventilatory velocity profiles. While high-frequency oscillation ventilation was previously considered as rescue mode of ventilation for severe ARDS, its use has fallen out of the favor. Previous study found a mixed result among patients with moderate to severe ARDS. In large trial of 584, 548 patients with moderate to severe ARDS demonstrated that higher in-hospital mortality in patients randomized to high flow oxygenation, high frequency oscillatory ventilation compared to conventional high PEEP and low tidal volume ventilation. However, the meta-analysis of the four study comparing HFO or high frequency oscillatory ventilation to conventional invasive mechanical ventilation, the association of high frequency oscillatory ventilation on 30-day mortality varied with severity of hypoxia. For patients with severe ARDS, the high frequency oscillatory ventilator was associated with improved mortality, wherein patient with mild to moderate ARDS, high frequency oscillatory ventilation was associated with worse mortality. So those societies recommended against routinely using high frequency oscillatory ventilation in patients with moderate to severe ARDS. There may be select patients with severe ARDS who benefit. Now, the next concept is the mechanical power. It is the amount of the energy transferred by mechanical ventilator to respiratory system per unit of time and is determined by the combined effect of applied tidal volume, driving pressure, respiratory rate, inspiratory pressure, and P, as well as the determinant of the mechanical properties of the ring. So the mechanical power might be more accurate parameter for lung protective ventilation because it considers the balance of all individual ventilatory parameters. Now, the mechanical power is calculated by using following formula. In volume control ventilation, it is calculated like this, and in pressure control ventilation, it is calculated by the formula given here. An observational study found no causal relationship between the mechanical power and mortality. And the mechanical power normalized to the compliance and to the amount of fail-related tissue was independently associated with ICU mortality. In general critical ill patient, the mechanical power of more than 17 joule was associated with higher mortality, and mechanical power of more than 22 joule was associated with increased 3-year mortality and 28-day mortality in patient with ARDS. In recent experimental study, mechanical power of more than 25 joule caused more significant and potential lethal lung damage than the lower value. Similarly, in patient treated with extracorporeal membrane oxygenation, mechanical power of more than 14 during the first 3 days was the only ventilatory variable independently associated with 90-day hospital mortality. However, the benefit of mechanical power is unclear and its clinical use is limited by complexity of measuring and interpreting it. And the other variables such as driving pressure are easily measurable at bedside and also predictive of mortality. Another interesting new parameter is the formula of COSTA, that is 4P plus RR, which showed that significant association with mortality and poor neurological outcome with better performance compared with mechanical power in patient after cardiac arrest without ARDs. Due to its potential advantage, this formula has been tested only as an observational association with outcome and deserved further investigation. This formula has been studied recently in patients without ARDS post-cardiac arrest. In secondary analysis from Roba et al., composite formula calculated as 4P plus RR independently associated with mortality and neurological outcome. This showed that after cardiac arrest, ventilatory setting in first 3 days after hospital admission influences the patient outcome at 6 months. Now, the next is proning. Prone ventilation improves oxygenation and ventilatory mechanics in many patients with severe ARDS. There is often significant heterogeneity of pulmonary edema, consolidation, atelectasis, affecting the dorsal lung region. Proning improves heterogeneity, allowing the increased lung recruitment, ventilation perfusion matching, decrease overdistension, and lung stress. These physiological effects have been demonstrated in animal model using electrical impedance tomography. In PROSEVA trial, the most notable study of early proning in patients with moderate to severe ARDS. Uh, in this patient, the PF ratio was less than 150. So they have studied the 28-day mortality in the pruning group was 16% compared to 32% in supine patient. And 90-day mortality in the pruning was 23% compared to 41%. So the average duration per pruning session was 17 hours and each patient underwent 4 pruning sessions on an average. The meta-analysis of pruning trial had shown improved oxygenation, improved mortality when pruning session lasts for more than or equal to 12 hours. So pruning is generally indicated in mild to moderate to severe ARDS, that is PF ratio of less than 150 after appropriate ventilator optimization. While paralysis may help to facilitate pruning safely, it is not required. In PROSEVA trial, patient continued pruning session until supine oxygenation improved to PF ratio of more than or equal to 150 and PEEP of less than or equal to 10 and FiO2 of less than or equal to 0.6. Therefore, smaller improvement in patient oxygenation should not necessarily halt pruning. If oxygenation does not improve, the patient may still benefit from improved respiratory mechanics, reduced lung stress, as mortality benefit was not directly linked to improved oxygenation. This may suggest that static compliance rather than the PF is more physiologically relevant pruning endpoint. However, robust data are lacking to support compliance-guided pruning strategy. Now, the next is fluid management. Acute lung injury during ARDS may be exacerbated by the fluid overload. The landmark trial conducted by ARDS network, that is FACT trial, compared the two fluid management strategy in the ARDS, that is conservative strategy and liberal strategy. The treatment protocol consisted of combination of IV fluid, diuretics, and inotrope based on CVP, pulmonary artery occlusion pressure, cardiac output, presence and absence of shock, and oliguria. While there was no effect on the mortality, patient treated with conservative fluid strategy had less fluid accumulation and increased ventilatory-free and ICU-free days. Non-invasive method, namely point-of-care ultrasonography, can also use to monitor hemodynamics and intravascular volume status. Venous congestion may be demonstrated by inferior vena cava dilation with poor respiratory variability and S-wave reversal in hepatic vein, while slow static feeling pressure may be seen with small IVC and small hyperdynamic LV cavity. The E by E prime ratio more than 15 is associated with increased left-sided feeling pressure, while if this ratio is less than 8, it is associated with normal left-sided feeling pressure, particularly when coupled with lung ultrasonography. Stroke volume and cardiac output can be evaluated using left ventricular outflow tract velocity, time integral, and diameter. IVC respiratory variation is the poor predictor of volume responsiveness in patient with severe ARDS, as this method was validated in patient receiving more than 8 cc per kg of ideal body weight. Respiratory variation of LVOT VTI represents better predictor of predicting fluid responsiveness, where differences in 15 to 20% is associated with uh, fluid responsiveness. Now, the next is glucocorticoid. The administration of empirical steroid for severe ARDS has remained controversial, and clinical trial results have varied significantly. One trial conducted found moderate dose methylprednisolone significantly reduced duration of mechanical ventilation, length of ICU stay, and ICU mortality. However, last study in 2006 by ARDS network showed no clinical benefit in patients treated with steroid within the 7 day of ARDS onset and increased mortality in patients treated 14 days after ARDS onset. More recently, DEXA ARDS trial studied in patients with moderate to severe ARDS and found that patients who received dexamethasone experienced more ventilator-free days and lower mortality. So dexamethasone has been shown to improve overall mortality in patients with hypoxemia due to moderate to severe COVID-19 pneumonia. So different ARDS phenotype display different responses to corticosteroid treatment. A latent class analysis of ARMA and alveolar trial revealed existence of two distinct phenotypes, that is hyperinflammatory and hyperinflammatory. The hyperinflammatory phenotype exhibit higher overall mortality. In retrospective analysis of COVID-19 ARDS had improved mortality with steroid, and hyperinflammatory group has worsened mortality with the steroid. While empirical use of glucocorticoid remain controversial in all patients with severe ARDS, there are likely select ARDS subgroup that derive benefit. Now, the next is neuromuscular blockage. Neuromuscular blockage improves oxygenation via several mechanics. The paralysis decreases the oxygen consumption, eliminate ventilator desynchrony, and improves thoracopulmonary compliance. The Accuracy's trial in 2010 demonstrated mortality benefit with 48 hours of neuromuscular blockage with cisatracurium in patients with moderate to severe ARDS with PF ratio of less than 150. The large multicenter ROSE trial in 2019 found no significant mortality benefit using a neuromuscular blockage in moderate to severe ARDS. However, patient already receiving neuromuscular blockage at the time of enrollment were excluded, and it is possible that subset of patients still benefit from neuromuscular blockage when deemed beneficial by clinical judgment. Additionally, in contrast to accuracy, ROSE control arm received the less sedation than NVM group, and which has been previously associated with ICU outcome. While it is evident that NBM improves oxygenation, it is controversial whether it confers mortality benefit. Prolonged use of neuromuscular blockage increase the risk of neuromuscular weakness, muscle loss, pressure injuries, deep vein thrombosis, and require deep sedation, which can increase delirium, neurocognitive impairment, and decrease ventilator-free days. When using neuromuscular blocking agent, train of 4 monitoring may be used to titrate the lowest effective dose. Deep sedation is also required during neuromuscular blockage and may be titrated using bispectral index to the goal of 40 to 60. Now the next is inhaled pulmonary vasodilators. Several trials have investigated the role of inhaled pulmonary vasodilators in ARDS, notably inhaled nitrous oxide and inhaled prostaglandins. Inhaled pulmonary vasodilators improve oxygenation PF ratio in most patients by improving ventilation perfusion matching and may be used in patients with the refractory hypoxemia. However, they do not improve mortality. Now, the next is fluid management. The optimal fluid management in ARDS is still unknown, and there are risk and benefit to the liberal and conservative fluid management strategies. FACT trial was defining the trial, testing the effectiveness of conservative fluid strategy in the ARDS. The trial adopted active fluid, active diuresis, fluid boluses, vasopressor, or inotropes based on the varying range of central venous pressure and pulmonary artery occlusion pressure. After a week, they found significant difference in cumulative fluid balance between the conservative and liberal deresuscitation group and ICU-free days compared with the liberal strategy group. Despite aggressive conservative deresuscitation strategy, which targeted CVP lower than 4 and pulmonary artery occlusion pressure lower than 8, there was no increase in organ failure between the conservative and liberal arm of the study. Moreover, there were no significant difference in the percentage of the patient receiving renal replacement therapy and average number of days on the renal support. Since this landmark study, the practice in the critical care has had significant shift. These findings suggest that the liberal fluid management may be more harmful in patients with ARDS by increasing pulmonary edema and prolonging mechanical ventilation days, ICU and hospital stay. Preventing fluid overload may lead to improved outcome, and active deresuscitation may mitigate lung injury associated with excess intravenous fluid without compromising organ perfusion. So different ARDS phenotypes may respond differently to the fluid management. In recent secondary analysis of the FACT trial suggests that hypoinflammatory and hyperinflammatory phenotype could differ with regard to the fluid responsiveness. In this study, subphenotype 1 was characterized by hypoinflation and higher proportion of white patients, whereas subphenotype 2 was characterized by hyperinflation and hypotension. So according to subphenotypes, the two different responses to the distinct fluid strategy were found regarding to the outcome. In subphenotype 1, mortality was 26% with liberal fluid strategy versus 18% with conservative fluid strategy. In subphenotype 2, mortality was 40% with liberal fluid strategy versus 50% with conservative fluid strategy. Hence, it is key to determine optimal volume status in each individual patient and to personalize patient treatment according to subphenotype. Now, our last treatment resort is the venovenous extracorporeal membrane oxygenation. This venovenous ECMO provides extracorporeal gas exchange in patient with the refractory respiratory failure and plays the critical role in the care of select patient with severe ARDS, though the selection criteria and timing of its use remain controversial. Studies have shown the wide array of outcome when comparing ECMO to conventional management. So, two notable prospective randomized trials for VV ECMO and ARDS are CAESAR trial and EVOLIA trial. So Caesar enrolls the patient with NORI score of more than 3 and pH less than 7.2. So Caesar randomized patient to transfer to ECMO center rather than ECMO itself. So of the patient that were transferred, 20% did not receive ECMO, of which 82% survived. And there was overall survival benefit when transferred to ECMO center. So next trial was EVOLA trial, which enrolled the patient with PF ratio of less than 50 for 3 hours and less than 80 for 6 hours with optimal ventilative strategy and adjunctive measures and pH of less than 7.25 and PCO2 of more than 60 while maintaining P flat of less than 32 and maximum RR of 35. Though there was no significant trend towards improved mortality in ECMO arm, and the study had intention to treat design, and 28% of patients in control arm crossed over to receive salvage ECMO therapy, of which 43% survived. So subgroup that benefited most from the ECMO were the patient with excessive ventilatory pressure and refractory respiratory analysis. The post hoc Bain analysis and meta-analysis suggest that ECMO provides 10% mortality benefit. With optimal ventilatory strategy for patients with VV ECMO are not clear, and the use of ECMO allows the lung rest with dramatic reduction in driving pressure, P-flat level, mechanical power, which may reduce the ongoing ventilator-induced lung injury. So higher PEEP and lower driving pressure while on ECMO have been associated with improved mortality and decreased cytokine release. So optimal PEEP have been evaluated in small cohort using esophageal impedance tomography demonstrated that most patients require PEEP to minimize overdistension, atelectasis, and improve compliance. So PEEP can also titrate at bedside to achieve optimal compliance. So when to consider ECMO in severe ARDS? So if PF ratio is less than 50 for 3 hours, if PF ratio is less than 80 for more than 6 hours, and if the arterial pH is less than 7.25 with PCO2 of more than 60 for 6 hours with the respiratory rate of 35, and if the ventilator settings are adjusted to keep P-flat level of less than 32. So this is the initial ventilator setting when the patient is on VV ECMO. If the patient is on pressure control and assist ventilation, then PEEP should be 10 to 15. Driving pressure should be 10 to 12. RR should be 10 and the FiO2 of less than 50. Then if the patient is on volume control, then the PEEP should be 10 to 15. Then tidal volume should be less than 4 ml per kg. P-flat should be less than 25. RR should be 10 and FiO2 of less than 50%. Then while the patient is on ECMO, we should consider serial transthoracic echocardiography and focus to monitor RV function. In patient with the RV failure, consider reconfiguration of VV ECMO and right ventricular assist device ECMO and adding pulmonary vasodilator and inotropes. So the absolute contraindications are catastrophic brain injury and irrecoverable cardiopulmonary disease. And relative contraindications are active hemorrhage, severe coagulopathy, contraindication to anticoagulation, immunosuppression, bone marrow failure, older age of more than 17, mechanical ventilation for more than 7 days, and expected survival less than 6 months, and multi-organ failure. Thank you, guys.